right, so chapter 7, lifespan development. So, big thing I was talking about note cards, and with note cards, if you looked at this chapter, we're looking at the different stages. We're talking about the physiosocial, the physical characteristics of different age groups from infancy through late adult. And the psychosocial, the mental and social, the characteristics of different age groups from infancy through late adulthood. And so, all through your healthcare career, you're not going to, this might be an obvious statement, but you're not going to treat the 2-year-old the same as you're going to treat the 48-year-old. And there's going to be a different approach to your patient assessment. There's going to be a different approach to how you're taking your vital signs, to how you're interpreting these vital signs. If you're assessing the heart rate on a 48-year-old and it's 120, what are we thinking? What's that? If you are assessing the heart rate on a 48-year-old male and it's 120, what are we thinking? We're thinking tachycardic. We're thinking that's fast. Tachycardic, using these terms. Start using those terms. If we're assessing the heart rate on a 2-year-old and it's 120, what are we thinking? I mean, how does he look also? You always have to preface it with that. You always have to say, is he perfusing? Does he look normal? Is he acting normal? So heart rate of 120 on a 2-year-old might not be far from their norm, but it's most likely going to be off the norm for a 48-year-old. So we're looking at these things, and we're looking at these age ranges here. And there's no other way, I think, than to do something like that note card and try to start learning these different rates. And we're gonna you look in the book where it starts on the table 7.1 with the infant's vital signs on page 158. So you see that it's going to give you the heart rate for your infant, the respiratory volume, the respiratory rate, and your typical systolic blood pressure. So looking at infancy, birth to 1 year, toddler phase, 12 months to 36 months, preschool age, 35 years, school age, 6 to 12, adolescent, 13 to 18. Then in adulthood, we're dividing it between early, 19 to 40, middle, 41 to 60, and late, 61. And we're going to see different things in different parts of it. Now this lecture really focuses a lot on kind of the early part of the life, the different physiological and physiosocial things as you're developing to adulthood. So infancy, of course, on page 157 is birth to 1 year. There we go. That. It kind of looked like my son, who came out with red hair, and I was really shocked. But found out it is a recessive gene on each side, so it's cool. The physiological characteristics, we're weighing, and we always think in kilograms, of course, so 33.5. 6.5 to 7.5 at birth. Weight doubles 6 months, triples about 12 months, and think about that. Think about how that must feel as you get that much larger. I mean, you're pretty much doubling your body. So this kind of maybe that explains some of the crankiness of babies at some point. The head is 25% of the body weight. Now these things are important also. Airway narrow, and we understand that. Easily obstructed. Nose and the diaphragm used for breathing. And when I'm looking at this, I think a lot also about CPR. You should think about these things. The American Heart Association Chain of Survival for pediatrics. What's the first link in that? Do y'all remember this? First link in the chain of survival for an American Heart Association for pediatrics. What's that? Do you remember it? Do you remember it? Y'all know what I'm talking about? I'm speaking Greek.
This is the first person on scene?
Maybe so.
Did I misunderstand the question?
Yeah, remember, there's 4 links in these chain of survivals. Maybe for adults. Do you remember what that was? What the first one is? Early access, calling 911. Right? Then in adults, the second is early. Right, CPR. Then the third is early defibrillation, and then early advanced life support, and then it moves into definitive care.
But on a child, don't you start breathing first before you call 911? Is that right?
Yes, but they've really tricked you on this.
Okay.
What they want you to do is they say the first link is prevention. So what are they saying? What causes cardiac arrest in most pediatrics? Respiratory arrest. What causes respiratory arrest in most pediatrics? They're saying. What's that? Choking. How does a little toddler or an infant that gets their hands on something choke? They put everything in their mouth, right? Who has a child? They explore the world with their mouth. I remember reading about that. I'm like, you know that? How do you, when you eat something and you say, that tasted like dirt. How do you know what dirt tastes like? Well, guess what? You've eaten dirt at some point in your life, and you did it probably when you were exploring your world as a toddler, and you went out there and you ate sand and you ate dirt, because I've seen my kids do it. So, thing I think too, airway is very narrow. That's a physiological difference that we have, us as an adult versus your infant. That especially think about the neonate. I mean, this 6.5-pound thing that you can kind of hold in your hand right there. How tiny it is. And how are you opening the airway? Think back to CPR. How do you open the airway on that infant? Remember, there's a term for it. Well, what would you do? All right, well, let's go back to our adult. How do we open what's the airway maneuver to open the airway? It's CPR. The hold the baby bird. Okay, chin. Head, tilt, chin, lift. Now, what do we do on an infant? We do the same thing. But, not as far back. Okay, good. So on an adult, we're going to hyper extend. On an infant, we're going to not hyper extend. We're going to get it. We're going to get them in. Remember that? Sniffing position. Like you're smelling something. Oh, it smells good in here. Hyperextension on the adult. You can, everybody do it right now, you can palpate your trachea, find your larynx. Remember how we're going to find our carotid artery, the landmark we're going to use to find the carotid. Find your voice box, feel your trachea, feel the hard cartilaginous rings down below it. That is your trachea leading down to the bronchi, down in your lungs. On an infant, how does it feel? Soft. They say straw-like. So if you tilt the head back too far, if you hyperextend, you're going to pinch it off, like you're pinching off a straw. You go to McDonald's and you mint the straw, and you're not going to get any air in. So we don't hyperextend. So the other thing I think about too, nose and diaphragm used for breathing. They're going to be nose breathers that a lot of times they're going to feed a lot. When they're in a feeding session, they don't take a break and take a mouth breath. They're going to nose breathe. And watching them breathe, watching that sub 12-month-old child breathe, how do we see them breathe? What are some differences between how we breathe and they do? I'm sorry? Okay, why is their stomach rise? They're using the diaphragm. We use their diaphragm. Yeah, and they're going to start getting developed. Chest muscles aren't developed yet. So we have all these muscles in our rib cage, intercostal muscles, that help us expand our rib cage out. Your infant does not have those muscles that help it expand its rib cage out. So we see that diaphragm expand to create that negative pressure that helps get the breath, and it pushes the belly down, up and down. So it looks like, that you see them, looks like they're belly breathing. But it's just so they can create this negative pressure to bring air in. For us, we shouldn't see that unless there's a significant problem with our rib cage. So, we're not looking, and that's the difference I think about. It was a CPR test question. I think it's still on there. How, when you're observing for breathing in an infant, how do you know that you're making sure you're getting good breath in when you're providing for back valve mask respiration? And you should see the what rise? Think about it. Where are we putting the air? Yeah. We want it to go where? In the lung, in the chest. So if they're breathing on their own normally, you're probably going to see a 2-month-old, 3-month-old, you're probably going to see their belly going up and down. If you're breathing for them, you should squeeze that little bag, it's no bigger than a bowl syringe, and you should see their chest rise and fall. And that's important for us to think about. We know that watching them is normal at certain age ranges that their belly is going to be going up and down. So again, look at that on table 7.1. Heart rate, 140 to 160 a minute. And this is where a good stethoscope can come in. Where are we assessing their pulse rate? On their arm. What's this artery up here? The brachial artery. So we're assessing their pulse rate there. Why not here? Maybe good. But everything's just so compact right here. Now, we might inadvertently compress their trachea, and that's no good. So we can assess down here at their brachial artery. That's quick. Sometimes, to me, it seems like using a stethoscope to kind of help confirm what a heart rate is on this child might be real important. 7, the respiratory volume. The respiratory rate, 40 to 60 per minute, drops to 30 to 40 soon after birth. So, it's real high pretty quick, early, and then we're in that 30 to 40 range per minute. Now, I challenge you to breathe 30 to 40 times per minute. Don't do it. You'll pass out. How many times do you breathe? And who's looked ahead? On average, as an adult, how many times do you breathe per minute? Breathe. 16, did you say 60 to 70? Should be about 12 to 20. Yeah. Right. So, start looking at this. Page 158, you're going to see some of these things. All right, a physiological characteristic too. Antibodies are passed from mother to child, pregnancy. Antibodies also pass through breastfeeding. And this gives that child, these are temporary, they say, when they're passed in this way. And when the child starts to develop them on their own, they're going to last for a certain period, maybe until they're 3, 6 months old, and then they'll start developing their own. So this kind of gives them the right start in life. Some physiological characteristics kind of for development. The Moreau reflex. Which, had it pulled up here. Skip it a bit. Okay, let's see. Oh, I gotta get through here. All right, here we go. All right, so here's our Moreau reflex. Watch this little guy.
Listed the Moreau reflex by having him relax unsuspecting and then give him a sudden stimulus, and there's a good Moreau, quiet and headlight midline, and then just do the stimulus of dropping him back a few inches, and that's a good normal response. Okay.
What was it? You got arms out, fingers spread out. There's our Moreau. Poor little guy. So that is a normal process of the normal stage of the developmental process. It's a physiological characteristics. When they're startled, you should see that Moreau reflex. And this could be, hey, how is this pertinent for us? This could be one of these things as you are assessing an infant at this age, if appropriate, if we're seeing how are they responding, what is our process going to be, or do we need to transport? Are they functioning in a normal way? You could try a startle type action, doing no harm, obviously, and see if we get a Moreau reflex, a Palmer reflex. I looked up one of those, but it's not nearly as visually fascinating. So what's happening on the Palmer reflex? And that's just fun as a parent, and you put it in there and bloop, and hold on to that finger. There it is. So your Palmer reflex, that's a good one too. Rooting, what are they doing on the rooting reflex?
So they turn their head towards, like if you were to touch their cheek.
Right.
And they're hungry, they would.
Yeah. Right. It's up there on top of page 159. When you touch the cheek, when she's hungry, she turns her head toward the side touch, and kind of indicating she's ready for feed. So, a sucking reflex sucks when the lips are stroked. Sleep patterns, and still having a 23-month-old, I kind of laugh at these. Begins to regulate after 2 to 4 months, then sleeps through the night. Extremities grow from a combination of growth plates and epithelial plates. So, we had my son at probably about 11 to 12 months, broke his arm. And, a little bit of cast, that big. And it ended up being just, a hairline fracture, but they weren't concerned about it because it wasn't on a growth plate. And so it's a big issue. Now, it's a big deal, but it wasn't as big of an issue because it didn't affect the growth plate, and his arm continued to grow properly. So that's one of those big things you're going to look at as well. Where is it? If there is a fracture involved, where did that occur? So some physiosocial characteristics. The fontanelles, not fused at birth. They are still soft until 9 to 18 months. The 2 sets of your fontanelles, the anterior and the posterior. Your anterior fontanelle is going to be that last one, they say, is going to start to fuse together. Now, what's the purpose of the fontanelle? Right? So you can be born. And so, those fontanelles on the side are going to start to fuse together, and then that top one is going to fuse in last. So this could be, though, an assessment tool. If you're assessing and you see that they have sunken fontanelles, it could indicate dehydration. Bulging fontanelles increase pressure inside of the skull, and both of them disturbing. I might think that the bulging fontanelles would be a more medically urgent condition. Bonding, are the needs being met? What kind of needs does, in this stage of development, what kind of needs does this little person have? You think about it, think about the chain. Of course, are we meeting, food, shelter, kind of stuff, but then beyond that, what are the things they need? That predictable environment, the need to know that where the caregiver is. Think about you as a care provider. If you're coming in to assess that 8 to 12-month-old, what kind of reaction might you have if you come in and mom hands you the baby, what kind of reaction might you have? They're not gonna be happy with you, are they? They want the caregiver back. They want mom back. So, trust, mistrust. Scaffolding. They learn based on what they already know. They're kind of building up. They're basing up these things. And I've been after 2 and on my third child is scaffolding us. She is teaching us how to raise her instead of us raising her. So, we really have to go back to ground zero and start back over. She's teaching us when she wants her, she's wanting her passy back. That's not good. She's wanting to get up in the middle of the night now, and guess what we did? We placate her and do it. So, they're going to learn. They're going to learn on this response. If she wants us in the middle of the night, she's going to cry out, and there I am, ready to go. So, they're pretty smart on that in that way. They definitely learn like that. Temperament, infants' reaction to the environment, how do they respond to you, and how are you going to assess properly based on that? How can you move in as a healthcare provider? They call for you. You've been asked to this place. Now how are you going to provide an assessment to look for some of these things we might have talked about? How can you assess what the respiratory rate, what the pulse rate is? How can you do this without causing more harm? What are some of the ideas you might think?
Let mom hold the baby.
Yeah, big deal, right? Let the care provider be involved in it. Not just, here you go, good luck. But, you hold the baby. Maybe we're going to start from the far end, not move into the kind of the invasive areas, maybe start with the foot. And this is completely different than how we're going to train when we start talking about patient assessment or primary survey a little while down the road in chapter 10. We're kind of starting always with that, ABCs. We're doing some of our ABCs, the airway, breathing, circulation, just by visually looking at them, maybe from a distance, talking about, we're going to get down lower. We're not going to be big and intimidating. So, those are some things you can kind of look at, and that can help you fit into this, the infant's reaction to the environment. We don't want to be, maybe this is more relative to me, the big old scary coming in, maybe more so than you guys. So. Now toddler phase, kind of fun, isn't it? 12 to 36 months. They really kind of get out and get involved in their world at this 12 to 36 month phase. So we're starting to look at our toddler on page 160. Look on the top of page 161. Your heart rate, 80 to 130. So now what you see is starting to go down. In this 1 to 3 range, we're going to see that. The respiratory rate gone down significantly, now 20 to 30 breaths per minute. Your systolic blood pressure, 70 to 100 systolic. So those are some of the things we're looking at. Pulmonary system, airways grow. The alveoli increase in number. Nervous system, brain 90% of the adult's weight. So we've got 90% of the brain that they're going to end up with. They already have from this 12, from 1 year to 3 years old. So it's pretty incredible. Musculoskeletal system, muscle mass and bone density increase. Immune system, they're more susceptible to illness. Immunity develops through vaccination. Teeth, have all their primary teeth by age 3. So some of the things we're starting to see physiologically. Psychosocial, begins to understand cause and effect. Highly curious and investigating. They're going to be out and about. They're going to be into it. This is that phase, right, when they're exploring their world. From that 1 to 3 stage, they're out there exploring the world with their mouth. Yeah, lots of stuff there you get in their mouth. This is when, like I think about, the prevention is one of the big deals that we in the EMS world, in the healthcare world, get out there and say, hey, you gotta be preventative in these things. You've got to lock your bleach up in a special cabinet. You've got to get small objects out of the place where they can grasp them, because if they get them, where are they going? In their mouth. So we're thinking about that during this time. Very curious about things. Separation anxiety can really start to develop at this point, right? And this can be where we come in also. We're coming in as the good guy, the healthcare provider coming in, but they don't like us. I don't want to be away from mom or dad. They don't want you to touch them, and this can pose a problem when we're doing a patient assessment. Begins to develop magic thinking, imagination, and ability to role play. Lots of really fun, great, cute things at this stage, right? So you have a great time with them. We have to remember where we fit into this. We got to try to ease our way into their world, not force our way in. Kind of even in that field healthcare provider role, come in and work with the caregiver to provide an assessment that's going to be valuable. The whole time we're still looking at these things. We've got to be aware, and you have to know, that chart there at the top of page 161. We've got to be aware. What is the typical heart rate? What's the typical respiratory rate? What's the signs that indicate that I'm too far above or below this? And I'm using that knowledge based on how my patient looks. This how is he perfusing? Based on the caregiver's history that they can give, how are they acting? This helps me in my decision tree. Whether in EMS, we're ultimately going to say, is my patient, we call it stay and play, or are they load and go? Because we're in the field, we're still thinking, do they need, right now, is it urgent to the point where they've got to get to definitive medical care? Or can we make decisions along with the caregiver as it relates to this toddler here? So those are some of the things we're thinking. So preschool age, 3 to 5. Pretty cool. Swing set on the beach. That'd be awesome. So the physiosocial body system continues to develop. And they're getting bigger, and this is kind of points where, maybe like with my son, when he realized that at this point he might really eat me out of house and home, go look for a third job for food. But body continues to develop. You see those feet getting larger, and you're like, oh my goodness, I just bought shoes. So the psychosocial, developing interactive and social skills. They're getting their little friends. They want them to come over. They're starting to be real fun. So we'll look down at the bottom and compare it at the top, table 7.5 with table 7.3. So now we've gone from toddler, which is 12 to 36 months, to our preschool age, which is 3 to 5. So now we stopped talking in months finally. Now we're talking years. So our heart rate, 80 to 120. So if we're getting a heart rate in this 3-4-year-old that's over 100, we're not going to necessarily be concerned, right? Unless, and you always got to preface it with that, unless what? What would be a concern if we have a heart rate over 100? Sorry?
It's irregular.
Okay, it's irregular. We're assessing that pulse rate. Where can we assess a pulse rate now? Where might you assess a pulse rate on this child? A school age. You could definitely do it on the carotid. How might that feel? What might a toddler say if you're kind of going into this, right? Yeah. They still might be at that point. I think, definitely in CPR we're doing it, but there's a difference when somebody might need CPR and we're assessing a carotid artery pulse versus, hey, can I assess your carotid artery? This is kind of getting right at the core of them. So, maybe you could try that radial pulse. Maybe you could try the brachial, a little bit less invasive. So some things to kind of think of. So now, we're in that 80 to 120 range on pulse, and that's normal. Respiratory rate, we're still going at that 20 to 30 minutes per minute. And I know we hadn't hit airway, but what do you think some signs and symptoms could be, even if his rate is normal, that they're not breathing well? Wheezing, you hear sounds, you hear abnormal sounds, wheezing, snoring, you know, the lower kind of airway sounds, the upper airway sounds. Yeah, and there's some things we're going to look at a little bit more, but you know, things I look at is what's their coloration? How do they look? Is he gray and ashen looking? Is he bluish, cyanotic? You know, those are things you take in along with that. So things you're going to know and things you're going to look at, we're not just looking at numbers. This is just a guideline to go by, and you've got to know these for these different developmental ages. But you also still have to assess in your patient assessment. How are they looking? How do they react? And is this normal? You're taking history, part of things that you as an EMT will do. Sometimes in the 3 to 5 range, you can't ask them things and get accurate responses. You might still have to rely on that care provider. Okay. All right. So moving through our school age, 6 to 12 years. You know, now we're out and about. We're biking a good bit. You know, we're doing more things here. We're starting to lose those baby teeth. Tooth fairy's coming. Very expensive. There's psychosocial, less general supervision. You know, now my 7-year-old wants to be on a device all the time. We bought a Nook. I want to be on that all the time. Developing decision-making skills. You know, they're starting to develop this. And yeah, I know as they move up towards that double-digit numbers, they're going to start to become and want more and more independence. More awareness of self-esteem. This is probably going to be the point. Does anybody have a child this age or have gone through this stage already?
Yeah.
I know with my nephews, you know, my oldest is 7. You know, it's that point where they're saying, you know, hey, drop us off a couple blocks from school and we'll walk. We don't necessarily have to have you right up at the door, you know? Right? So I'm not looking forward to that. So more awareness of that kind of stuff. Values the opinions of peers, positive and negative, and they're going to start to become a big influence in their life. So, you know, these are things too you have to be aware of when we're assessing this age range of child. Your adolescent vital signs that were on table. We're at school age. I'm sorry. Your school age are on table 7-6. Heart rate 71-10. You know, respiratory rate, we're going to hang in that 20 to 30. Systolic blood pressure now still probably low. Your upper end of it 120, which is what an adult would be. And you think about it, and I've seen them. Have you seen a 12-year-old that looks like a full-grown adult? I mean, I have.
Yeah.
Whoa.
Well, they're heavy too.
How old are they? Yeah, right. Definitely can. So some of the things we're looking at on there, and you see how these vital signs are flowing. You're seeing how the pulse rates are getting lower as they get older. The respiratory rates getting lower as they get older. Systolic blood pressure going higher as they get older. All right. So adolescents, 13 to 18 years old. Some physiological characteristics. Have a growth spurt, and this is where it talks about in the book. You know, those feet are going to get huge, hands get huge, and then they're going to kind of grow into them. Arms, legs grow in, and I try to imagine how this might feel. You know, and for us, you know, we've probably planed, and you're probably where as tall as you're going to be. But imagine if, like, over the course of 6 months, you got like 3-4 inches taller. You know, it'll change your center of gravity, and you can become clumsy. You know, things are changing. I mean, and can be that growth spurt can be a real tough time because, you know, you're getting bigger and you're dealing with kind of a new body here, new parts of you are growing. So that's a tough thing to kind of deal with. Then during this adolescent stage, also they're going to reach sexual maturity, and some people talk about the in the school age, we can start to see the onset of puberty, and it typically comes first in females more as opposed to males, and the males tend to kind of develop slower in these regards also. So these are some of the things you're going to see. The adolescent strives for independence. At this point, hey, don't even bother taking me to school. I'm just going to hitchhike. I'll go in. You're going to ride the bus. I'm not going to ride the bus. I don't want to be seen on the bus. So we're going to see some of those things. Reaching sexual maturity also can be an issue as well. If you look at our age range for an adolescent, 13 to 18 years old, and we're still in school. You're still not independent, though they want to be. They've reached sexual maturity. Now, what are some of the things that might come into play? And the book alludes to sexually transmitted diseases, things such as that. The book also talks about ectopic pregnancies. Some things that we discuss, when we get certain chapters are abdominal pains, acute abdomen. In females of childbearing age, you have to start to try to rule out pregnancy. When was your last cycle? What's the date of your last cycle? Are you sexually active? Mom called, you're the EMT, and you're talking to a 14-year-old. Are they going to be completely upfront with you?
No.
Yeah, they're going to flat lie. They don't want mom to know. So, these are some things, and you're not going to call them out as a liar. But, how are we going to get the truth? So, to me, I know that was the thing that was always very frustrating as an EMT, to ask questions and not get accurate responses. Deliver them to the ER. They get right to a nurse. The nurse says, possibility you could be pregnant? Yes, absolutely. I asked you that question. They didn't say that to me. But so, we just have to be aware of this. I know a lot of times, too, I thought about this. Out in the field, I know where I worked, we would, wear the button-up shirt and it had a badge on it. So you kind of look like you're a police officer. And so a lot of times, have you been drinking, any alcohol, have you taken any drugs? No. You get to the hospital, any alcohol, you've been drinking. Oh yeah. This, that. What am I going to do? So we try to explain those things, and you just have to be aware that's one of the things that happens. And you, as the healthcare provider, have to try to understand that there could be this wall that can be built there. I would never throw stones or be accusatory in any way, but maybe one of the things that we're doing, like Lyndall said with tuberculosis. One of the things that we're kind of looking at, you hear in your test question, night sweats. That should be a thing that pops up, tuberculosis. And we're thinking of this and we're preparing ourselves in that way. That's when we might pop out those respirators and be ready for that and start moving down this path, though we're not diagnosing it as such. Okay. Things such as this in this age range, or any sexual mature childbearing age range, we're not diagnosing as that. We're just not. We can't rule it out either, unless they can definitively rule it out, right? Okay. So, some of the things we got to you start opening up to really in this age range. Concern about the body image, also a big deal, right? I know some vehicle accidents that I've been to, not just in this age range, but it seems to be a concern. We tell, we're upfront with what we're doing, what our treatments are, and they would be possibly concerned about what they look like. looks like you broke your nose, or how does it look? You know? We're not supposed to lie. It's horrible. No. But this is when you kind of bend the truth, right? We are doing our best to make sure you're as comfortable as you can be, and we're going to get you into some help. You know? So that concern about the body image and peer pressure are a big deal. Self-destructive behaviors, right? We've probably all been aware of those, been around them. You know, I had friends that would do some crazy things, and I'm glad I didn't do some of them. And you know, I remember in this age range, I had some friends that lived down the street from me. They had a pool in their backyard, in their front yard, 2-story house with a basement in the back, so it was 3 stories. And they got where they were jumping off the roof into the pool. Well, that wasn't good enough. They had to do it at night, or they turned off all the lights. You know, why do people do this? You know, how can you explain that out? They said it's so fun. You got to do it. Like you just jump and you don't know until you get the water. Yeah, that's what I want to do. So definitely that's self-destructive. Developing that personal code of ethics. You know, so hopefully it's going the right way. Hopefully they've gotten a good mentor in their life, and they're developing the right code of ethics. Think about it. Adolescents are often injured because of risk-taking. Maybe resistant to disclose what happened, you know, in a lot of different regards, right? Must be encouraged to explain circumstances surrounding an incident. And, you know, this can be tough. This can be tough for you out in the field. This can be tough if they're with a person of authority, you know, and you run into a lot of legal issues there at this point. At what point do they have the right to refuse treatment and transport? At what point do they have the right to get it on their own? You're kind of running into that in Alabama at this point. So, you know, there's a lot of complicated issues that typically will arise for us in pre-hospital care, and that's where sometimes online medical direction becomes real valuable when you're out in a pre-hospital setting. You know, mom and dad, if they have, if you have a child, you know, of a certain age, they're going to have a right to know what the treatment is, what the, you know, what's going on with their child. So yeah, and if the mom and dad are there, they're probably not going to want to say anything about what happened at all. So, a lot of working together has to happen. So early adulthood is 19 to 40. Start hitting early adulthood on page 164. You look at the early adulthood vital statistics there on table 7A. Your average heart rate, 70. Your average respiratory rate now, you know, this is where we're thinking more along what we looked at in CPR as the adult, according to American Heart. The adult, you know, 12 to 20. Now we're right at that. You know, your adolescent there, you know, right at that 12 to 20. Early adult, 19 to 40. You're up at that 60 to 20. Blood pressure, pretty good. Your systolic 120 to 80. So these are things we're looking at with our adult. Physiological, lifelong habits are formed. Reaches peak physical condition during this period. Psychosocial, job, family stress can start to develop in this. Typically you might be seeing, you know, you're moving through, you set up what you're going to be doing as a career. You might have developed have a family, you know, got a 30-year mortgage. There's real legit responsibilities that you're looking at, dealing with. So, you know, that job, hey, now it's not just like, man, I have a fun job and this gets me to do things that I want to do, but I've got a job and I can't lose it, or else I'm going to go to jail because I can't pay all the responsibilities that I have. So that stress starts to develop there. Marriage, children, childbirth, child rearing, that's a real deal. Accidents are the leading cause of death during this phase. You're kind of in your peak physical condition. So, typically what's, the leading causes of death is going to be something accidentally happens, typically. Middle adulthood, 41 to 60, you're in yoga classes, typically, or whatever this is. Physiological, may need vision correction. Cancer, heart disease often develop. That's just the common thing where you're going to see a lot of this stuff. And I think about this, you were born, the vessels that you have, your circulatory system, your pump, your heart, it's the same one you carry with you your whole life. And now, at this point, you've had it from 40 to 61 years. So, it's getting a little bit older. What have you done to it? What's happened? How did you care for it? So, this is where I might start seeing some of these things like, man, I was 19, sure did like smoking. I developed that lifelong habit. It's hard to drop it, and it's a bummer we got cancer. Sure did. Wish I'd laid off those Big Macs through my 20s because I really developed a taste for them. And we're starting to deal with these and see some of these consequences, maybe unintentional, that have started to develop. And that's where we in the healthcare world come in. That's where we're seeing some of our patients in this way. Weight control more different, your metabolism changes. Due to some things, it might be more difficult to get out and do the things that you had done before. It's more difficult to exercise because you hurt more. There's more of a more difficult recovery on certain things. So that just lifestyles in a lot of cases may become more sedentary. So weight control becomes more difficult. Some cases, and this is broad sweeping things, right? This isn't everybody, but you might get an empty nest syndrome. It could be caring for elderly parents in this stage also. So some of the things we may see. Late adulthood, they define as 61 years or older. Body systems less efficient. Excuse me, YouTube. So, less efficient. Again, and I kind of think about it. You've had this pump that's been pumping away. It kind of starts off at that 120 to 160 range, and it pumps. We're probably going to, on a lifetime average, we're pumping 80 times a minute for now, at least 60 to 80 years now we've been going. We might start to see some issues that start to develop. So, with this pump, and you got to think about all the other stuff that's involved with making sure everything is good with it. How's our vascular system? How are our vessels? Do we have atherosclerosis? All these things lead into making sure that pump is good to go. So our body systems, it's just going to happen, isn't it? We're getting older. It's going to become a little bit less efficient. And the trick, I think, is being able to deal with it. So you, working with your late adulthood patient, have to realize that you may see some things that are going to be related to this. That you just had the same ticker now for 75 years. Might be a little bit less efficient. You might have to treat it as such. The psychosocial, the living environment, conditions may have changed where they live. Self-worth, so it varies so much, doesn't it? What are they tying their self-worth into? To me, it seems like you're looking at a lot of people in this age range are approaching retirement. And maybe for so many years, their self-worth has been related to their career. If I retire, what am I going to do? What am I worth? What's my worth? What's my reason to get up in the morning? So some of the things you might run across. Financial burdens could be it. Could be really, really difficult, maybe, especially if they're on a fixed income and something rises that they didn't expect. Death and dying, this is where we might think about the DABDA. Remember the DABDA? Maybe they're dealing with an issue. Maybe they're dealing with one of the most stressful things they say in this age is the loss of a spouse. And they've lost a spouse and have dealt with that. Maybe they're dealing with their own. And so these are some things you might run across and have to be aware of. So, the other thing I look at, and try not in any of the age ranges, think of that, maybe the ones that they're aware where you can really start taking accurate histories. Definitely in this late age range, we tend to kind of think certain things and treat them in certain ways. Coming in, a little lady is called for difficulty breathing. And if you come in and say, "How are we doing today?" Do we know that she has a hearing issue? And so, you're not going to necessarily, why are you yelling at me? Oh, I'm sorry, my fault. And some things that the book will talk to you about, how to treat those and treating others with respect, and knowing some of these lifespan, not just vital statistics, but some of the physiological things, and keeping that as a background or a backdrop, a foundation for building this assessment, I think is going to be real vital. So this helps you with communicating with and assessing vital statistics. Infants and young children has less developed smaller respiratory structures, and this can worsen the respiratory conditions. So we got to know that, and you got to be aware of that. Communicating with patients depends on their stage of development. It could be fear of strangers, and where's our fear stages really? Yeah, that pediatric, that young, toddler really. Your preschool, and maybe even in early school ages, separation anxiety, embarrassment. Where might we see denial and depression typically? And maybe you're middle adult, late adult, maybe. Yeah, but again, it might not be limited to that. We have to be aware of that. Infants present massive bursts of anatomical and psychosocial development in the first year of life. That's well put, isn't it? Although preschoolers begin to develop independence and reason, in many ways they still resemble the psychosocial development of toddlers. School-age children are often independent and logical, but that may crumble with illness or injury, right? And probably a lot of you have seen that when they, such a big kid, they get that injury and they can seemingly revert. And I think that's just something that you can expect with a child in that developmental stage. Adolescents are reaching maturity, but they often face difficult psychosocial challenges. And it's hard for us to kind of relate sometimes when you think, man, they just made such a bad decision. Why would they do that? They don't have the experiences that we may have had. And then you have to think, I made some bad decisions, and that's how they got to where they are, or to where I am. So, fortunately, a lot of our bad decisions might not have landed us in the hospital. Maybe with some they do. Early, middle, late adults vary greatly in terms of psychosocial development and conditioning. They also face psychosocial challenges that are unique to adulthood. All right, here's a question. Does the age of my patient pose any assessment or care challenges based on the physiologic development? What about the elderly? Does it pose any assessment or care challenges based on the physiologic development? Yeah. We'll see it. We see it at certain times, maybe in the musculoskeletal. And what's kyphosis? I don't know what that is. Curvature, right?
Like scoliosis, but the opposite way.
You might be thinking of lordosis, like this way back. Or the kyphosis is, have y'all seen that?
Yeah.
And how does this present a problem? What if you have an elderly patient with kyphosis who's been involved in a motor vehicle accident, and you need to provide spinal immobilization? Hearing difficulties, vision difficulties, dentures. Or the question we had the other day. What's the difference? And we kind of tied it into being an advocate for this patient. Would it be worth it if they're not urgent to take that extra time and get their class? Let them put their dentures in. And if it's not that medically urgent, load and go. We got to get you out now, kind of thing, right? How does it pose a difference with our pediatric? How are we going to get accurate information? And I think we all are concerned about this, and we alluded to this yesterday. Biggest fear that you're going to, the biggest fear call that you have, right? I said, child. A child is an issue. Child in this certain situation. And I think, those of us in the healthcare world, that remains to be one of ours. Thinking, what's the situation? What are the specifics to what we've been called to? To the traumatic injury, etc., illness, and how are we going to go in, and how are we going to assess and get good information and make good decisions on this pediatric patient? You can't ask that toddler age, what their medical history is, and you don't expect to get that right. And sometimes we've got to start to make these decisions based on presentation, and we start to look at this as we move into our patient assessment, which again is going to start with the next chapter we're looking at today. All right, so here's the end of this. So does anybody have any questions on lifespan development? Again, we're kind of building this foundation, this pyramid, to kind of start stacking other things on top of. And I think it's kind of good we're going to start into kind of the first, maybe the easiest part of patient assessment next. All right? All right, no questions. Let's take a little break and come back. And see if I can stop this.